All right. So I'm Connor, and I'm going to tell the general anatomy of and physiology of the shoulder. So what is the shoulder? The shoulder is a structure that is made up of the scapula and the humerus bone. This is a picture of, of the shoulder. Just gives a general idea and gives some key areas. What is it made up of? The shoulder is made up of the shoulder girdle and the shoulder joint. There are also multiple other little joints within this also. And this shows a picture of the girdle, and the joint is right on the far left. It's called the glenoid humerus joint. So the shoulder girdle. The shoulder girdle is made up of the scapula and the clavicle. The scapula is a triangular bone. It's actually directly right here in your back. It also connects to the clavicle, which is right here. And the clavicle is what connects the muscles to the humerus. All right. So there's you can see the clavicle over the scapula. And the scapula connects to the sternum. It is the only place in the whole body where it actually connects to the trunk of the body. Also, the scapula and the clavicle, any movement with one, the other moves as well. All right. So there are also a lot of key points within the shoulder girdle, and there's a bunch of them right here, and I'm not going to say any of them because it's just going to waste a bunch of time. All right, the muscles consist of the trap, which is the like shoulder, like the top of your shoulder area, and it kind of comes into your neck. The rhomboid, it connects your shoulder blade to your spine. So it's actually that middle muscle that connects the two of them. The levator scapula is what connects your shoulder blade, and it actually makes it stay in place. It's connected to your neck. The serratus anterior, it is the rib cage muscles in the front that actually connects right here, and it comes back around and connects to the scapula. And then you have the pectoralis minor, which is the lower pec. It also connects to the serratus anterior, and all that goes back to the scapula. Here's the movements of the shoulder girdle. You have abduction, which is the movement. It's whenever you lift your arm up. Whenever you lift your arm up, it actually rotates counterclockwise. Your scapula does. The upward rotation is the exact opposite, where you come down and it rotates clockwise. The depression is where the downward rotation, or the the downward rotation is just where your shoulders drop, and then you have the upward where it goes up. Okay, so now you have the joint of the shoulder. The joint of the shoulder has the glenohumeral joint, which is that main joint right here. This one right here is multi-axial, and it's the main joint of the shoulder, obviously. It connects your upper limbs to the trunk of the body. It's also the only point in your body where it is connected to the trunk. All right, so you got the bones here. You have the humeral head. The humeral head connects into the glenoid cavity, and that right there is where the glenohumeral joint is. you have right here, you have like a front facing, and then you have a posterior and anterior side facing view of the scapula. And what it just shows the like the indention there where the humeral head will enter the scapula. The clavicle in this also, it's just all it is an attachment point for muscles for the shoulder. Really the bone is there just to give ligaments and muscles a place to attach. All right, here are the muscles in the joint. The ligaments in the shoulder joint actually are very lax, and whenever they're also very stable in a just a regular position. But whenever you really extend it, it actually takes away a bunch of the stability, and it gains mobility. So the more extremely you like move your arm, the less stability you'll have, but the more mobility you will have. All right, so here's the shoulder joint movements. You have the abductor, where basically it's your an upward movement towards your head. Then you have the adductor, which is the exact opposite, where you go back down. You have the flexion, which is where the flexion goes in front of you. So the flexion, you'll be moving your arms this way. And then you also have the extension on this one, which is where your arm goes straight back. These were supposed to move, but they aren't moving. Then you have these right here. It's horizontal, and it's just the two horizontal versions of it. So basically it's the same thing, only you're going inward and then outward. That's it. Then the other one, the external rotation, basically it's exactly what it says, where your body's going to externally rotate. You're just to your side and it goes over. And then the internals is the opposite. And there's my references.
Okay, so our first section, we've got our first injuries we're talking about are the slap lesions and AC joint sprains. So first is a slap lesion. It is called the slap lesion because it's superior labrum, anterior posterior. So all of like pretty much your true shoulder joint is just, there's the glenoid labrum in the middle of it, and that is torn by the biceps tendon. So articulations are the humerus and the glenoid fossa that sits on the lateral side of the scapula. It just sits in there. It is the true shoulder joint. So you have all of the movement, all of the mobility. And then the bones, the head of the humerus, and then the scapula. So next we have ligaments. So for a slap lesion, the biceps tendon tears on the labrum that sits in the middle of your shoulder or sits around the humeral head, and it tears away part of the labrum. So when that happens, it becomes ruptured, and a lot of the symptoms, and it really displays almost like a rotator cuff injury because it is same area and deep inside the shoulder. So like I said, the muscles displays like a rotator cuff injury. It works all of those muscles. there is also serratus anterior on the front side of your body, and your rhomboid major and minors in the back, your levitator scapula in the neck, and then your traps. So signs and or epidemiology of SLAP lesion. So most common mechanism of injury or the etiology is usually a repetitive problem. It's or direct trauma. So it can be displayed over a course of somebody's whole life, or it can result from an acute injury like falling on an outstretched arm, or you go to pick up something heavy and it just ruptures because your biceps tendon is too strained and it pulls away the labrum. So signs and symptoms is everything you could expect from part of your body tearing out of place. Lots of pain and swelling, a very deep, but the most telling sign is a very deep, unlocatable pain inside of the shoulder, and no serious deformities, because every time they move, because the head of the humerus sits inside of that labrum, every time they move, they're going to feel it, no matter where, what direction or plane of movement possible, it is going to hurt. So assessment, there can be one of six, at least six types of assessment, just named type 1 through 6. There's the first, which is there's no actual fraying or detachment of the biceps tendon from the insertion. So it is still intact, but it is just a serious strain. Type 2 is the most common. It is a detachment of the biceps tendon from the labrum and glenoid rim. And next, type 3 is what's called a bucket handle tear. And it is a tear from the labrum with an intact biceps tendon. And then types 4 through 5, or 4 and 6 are just, increasingly worse. And they all just come in conjunction and with the previous injury or previous symptoms all lumped into the next category. So biomechanics, similar to what Connor said when describing the movements of the shoulder, because it is the true shoulder joint, it can do all of those movements in all three planes of movement and on all three axes of movements. But typically, repetitive injury for a SLAP lesion is going to be the biomechanics, like a repetitive overhead movement. So our next injury is an AC joint sprain. So the AC joint sits superiorly on the top of your shoulder where the clavicle meets the acromion process of the scapula. So like I put on here, the acromion and the distal head of the clavicle is where this is going to happen. It is the AC joint connected by the acromioclavicular ligament, and then the bones that go with it are the scapula and the clavicle. So the ligaments involved are the acromioclavicular joint, the coricoclavicular joint, the coricoacromial joint, and the ligament and the trapezoid ligament. So the coricoclavicular ligament and coricoacromial ligament go from the coracoid process uh, up to the clavicle and acromion. And then the trapezoid goes from the clavicle also down the coracoid process, and then the acromioclavicular ligament attaches from the distal end of the clavicle to the proximal side of the acromion. So muscles involved, the deltoid and trapezius, their attachments mesh with the acromioclavicular ligament, and usually if there's a rupture of that ligament, there is also some damage to those attachments in there. And also, if there's a serious force coming from either one of those muscles, it could rupture the AC ligament. And then also included are the pec major and the sternocleidomastoid, because they both attach at the proximal end, or the medial side of the clavicle. And again, just a major force from those muscles could, put that out of place, even if it's just slightly enough to cause an injury. So signs and symptoms, an AC joint mechanism is most likely a direct blow to the shoulder, whether it's, hitting a hit from somebody, or you fall on the ground, or falling on an outstretched arm. That will jar your AC joint, and it could rupture any one of the 4 ligaments on the inside. So signs and symptoms, you will usually have a pretty obvious deformity where the clavicle pokes up out of the shoulder. And even with a very mild AC joint sprain, there could still be some deformity. Signs and symptoms, it'll be pain with movement. I'll cover those movements in a second, but just any kind of pain, deformity, point tenderness around the shoulder. And so moving on, the AC joint is also classified with 6 levels of severity. So 1 is all of and you can see here on the right. So 1 is all of the ligaments remain intact. There's no major deformity, but it still could be very painful. Type 2 is a tear of the AC joint and the core, or the CC joints. The second is just a rupture of the AC joint. Third is a rupture of all of those ligaments, and the clavicle is no longer attached to the scapula in any way. And then the fourth is all of the ligaments are detached, and it is posteriorly separated from the acromion. So it is completely out, hard to get back in. Then 5 and 6, 5 is a superior dislocation, and then 6 is very severe, and it gets tied up with the coracobrachialis muscle. Grades 1 through 3 are usually treated conservatively, and 4 through 6 require surgical intervention as close as possible. So biomechanics. So the AC joint allows for any adjustments of the scapula. So elevation, inward rotation, and retraction. It has all 3 planes and axes of motion, but to a much lesser degree than the true shoulder joint. And here are my references.
My name is Morgan Aker, and the two shoulder injuries that I chose to do are a frozen shoulder and glenohumeral internal rotation deficit. Okay, the first injury that I did is frozen shoulder. The bony anatomy involved with frozen shoulder, the articulations are the head of the humerus with the glenoid cavity of the scapula. The joint is that glenohumeral joint, which is the true shoulder joint. And then the bones are the humerus and the scapula. The ligaments involved with this are the glenohumeral, coracohumeral, transverse humeral, coracoclavicular, and coracoacromial. The muscles involved with this are subscapularis, supraspinatus, infraspinatus, teres minor, and the biceps tendon. So in the picture that I have shown to the right here, the coracoacromial ligament is where that coracoid process meets with the acromion, and that's what's shown in yellow at the top there. Coracohumeral is where that coracoid process meets with the humerus, and that's what's shown in the pinkish reddish color. And then glenohumeral, which is shown in blue, is where the glenoid cavity meets with the humerus. The biomechanics and the range of motion involved with this is your passive and your external rotation, passive and active external rotation are going to be severely affected whenever you have frozen shoulder. Under normal conditions, you'd be able to easily move through all three planes with this, but with this injury, you're going to have very limited range of motion. The etiology of this, the cause isn't really fully understood by researchers. They think that if this immobilization that you experience with this disease, it could be, or this injury, could be due to having surgery or even other health problems such as hypothyroidism, hyperthyroidism, Parkinson's disease, or things like that, or things that researchers think could put you at risk of developing this shoulder injury. This is an injury that's more so common in the older populations, not really something that affects younger people as much. This happens mainly in people that are above 40. I saw that this mainly affects people between the ages of 40 and 60. And then treatment of frozen shoulder, non-surgical treatment can be done with acupuncture or non-steroidal anti-inflammatory drugs, which are things such as Advil and ibuprofen, just to help get swelling down. And then it can also be treated using oral steroids or even steroid injections, hydrodilation, and physical therapy. And then surgical treatment involves manipulation under anesthesia, which is where they put you to sleep, and then the doctor will just force that shoulder, which will cause the joint capsule and the scar tissue to just stretch, and that will help you get your range of motion back. And then or shoulder arthroscopy, which is kind of similar, but in this one, they're actually cutting into that joint capsule to help get that range of motion back. And so with this one, there's 3 different phases that it has of a clinical presentation. Phase 1 is called the painful freezing phase. So in this phase, your pain is going to slowly progress, and you're going to lose your more range of motion. This can last anywhere from about 10 weeks to about 36 months. And then phase 2 is called the adhesive phase. Your pain might improve a little bit in this stage, but you're still going to be like super stiff. This can start anywhere around about 4 months and last up to 12 months. And then phase 3 is your resolution phase. Your range of motion is going to improve slowly, but to get back to normal is going to take anywhere from around 12 months to about 42 months. So with these phases, they all kind of have a different range of how long it might take to begin. And so it kind of varies for everybody. And then the next injury that I chose to do is glenohumeral internal rotation deficit. This picture that I have shown here is just showing that external rotation and internal rotation similar to what that of an overhead thrower would do. And this injury is very common in those that participate in overhead throwing activities such as softball, baseball, tennis, handball, and even javelin throwers. Okay, the articulation of this is the humeroid, the humerus and the glenoid of the scapula. And then the joint is that true shoulder joint, the glenohumeral joint. And then the bones involved with this is the humerus and the scapula. The ligaments involved is the glenoid labrum. And then the muscles involved are the infraspinatus, supraspinatus, teres minor, and subscapularis. The biomechanics and the range of motion that are involved with glenohumeral internal rotation deficit are you're going to have a great loss of internal rotation and a total rotational motion. Loss of greater than 20 degrees of internal rotation is indicative of a GIRD, and total rotational motion loss of greater than 5 degrees is also indicative of this shoulder injury. Yeah, so you're going to have not really be able to move, like internally rotate much at all. The etiology of this disease, they think it could be caused by a posterior rotator cuff tightness and posterior-inferior capsular tightness. So they think these two things are what could lead somebody to gain that shoulder pathology of this disease. And like I mentioned before, really common in in overhead throwing athletes because of that repetitive cocking motion that overhead throwing involved is really detrimental to that shoulder joint if you're not getting proper care and icing of that repetitive motion is really harmful. And it causes lesions. That repetitive cocking motion causes lesions to the posterior-superior labrum. Signs and symptoms of glenohumeral internal rotation deficit. You're going to have pain, and it's not going to be specific to any certain area of the shoulder, but the pain is more so going to localize to the posterior on the back of that shoulder. Signs of this is something that they call sick scapula. And what this involves is a scapular malposition where your scapula is just not really sitting exactly where it's supposed to. Inferior medial border prominence, pain and malposition of coracoid, and scapular dyskinesis, and posterior-superior labral tear. So yeah, with this, it's due to all those like repetitive cocking and motions involved with all that overhead throwing. That's really just gonna mess with that joint capsule and just make you have a lot of pain there. And from what I read with research, a lot of times they have a hard time diagnosing between different shoulder injuries just because of how similar the signs and symptoms are, like stiffness and that localized, or not even really localized pain, more so generalized pain. That makes it really hard to diagnose exactly what injury it is. I read for this one, and I think also even frozen shoulder too, that they present very similarly, so it's hard to determine which shoulder injury it actually is. So like both GIRD and frozen shoulder could potentially present as a rotator cuff tear. So that's something that they're working with too, just at ways to better tell the differences between the shoulder injuries to be able to diagnose them more easily. And then treatment for this, for GIRD, is going to be physical therapy. It's just going to involve really extensive stretching just to try to help get that range of motion back that's been hindered by all the tears and things that have been created. And then so that was for non-surgical, it's physical therapy, but then for surgical, they really only want to do surgery for those who didn't experience who didn't experience any success with using treatment. So it's really, they want it as like a last resort option, but they will do arthroscopic surgery which is similar to that I had mentioned for frozen shoulder, which would just involve them cutting into that joint capsule and seeing what they need to cut or just repair just to help get that range of motion back. And then here's my references. Thank you.